Hello all, my name is Dr. Paresh Naik and welcome to Virtual OR. Today we are going to have a look at maxillary sinus antrostomy with biopsy. So let's begin with the scans. So we had a gentleman who had CA prostate and for which he underwent PET scan. So on PET scan, an incidental uptake was noticed on the right maxillary sinus, ethmoid and frontal. Quite interesting. Further, the CT scan showed similar findings. What you can see on the scan is the right maxillary sinus is opacified. The ostium is blocked as well. There are some bony changes noticed. This can be a mass or collection. So we plan to do an examination under anesthesia with biopsy of right maxillary sinus. Now this is an unedited video. We started with the usual nasal decongestion. The decongestion is one of the very crucial steps. As you can see right now, there is hardly any passage. You can use ribbon gauze, you can use neuropathies, or sometimes people do use Merocil as well. The ribbon gauze is soaked with 1 in 10,000 adrenaline. You can use Moffat's solution as well, but 1 in 10,000 actually acts in the similar fashion of that of Moffat's. 1 in 1 lakh solution or 1 in 100,000 solution doesn't act that well. What you can do is you can use this ribbon gauze and put in the nose for some time, leave it for some time. Now this is a real time. You can see in 1 minute what is the action of 1 in 10,000 adrenaline in the nasal mucosa. This action is almost similar to that of Moffat's solution. I'm using some more adrenaline and squirting on the top of the ribbon gauze. This is the left side of the nasal cavity. People at times use 1 in 100,000 or 2,000, but it technically doesn't have the same effect of 1 in 100,000. This nasal decongestion is very important as it is going to help in getting a clearer field. You need to request your anesthetist. You have to convince them that this is important. Buy them a coffee or a pint or play their favorite music in the theater. But please, we need to know that nose preparation is very important. Now talking about nose preparation, what do you think about using as a painting solution? Do you think povidone iodine is good? Or do you think that chlorhexidine, that is chlorprep, is good or nothing? Well, in many centers, just normal saline wash or not even cleaning is quite considered normal because our nasal mucosa already has a lot of bacteria. We can use betadine washes, the dilute ones. Actually, during COVID time, we were using a lot because it was supposed to be protective against SARS and COVID virus. But however, there is a loose association between impaired ciliary function with the exposure of betadine or povidone iodine. The chlorhexidine, I know for sure that the patient has a lot of irritation. Also, one more thing that we have noticed is that whenever you give a wash with chlorhexidine or betadine iodine solution, there is generalized congestion. Now we are taking the ribbon gauze out. As I said, this is a real-time video. No editing has been done. So the ribbon gauze with 1 in 10,000 adrenaline was sitting for just 2 minutes, and see the amount of decongestion it has caused. You can actually see blanching of the tissue. Imagine if this you would have left for 15 minutes. So in many centers or many surgeons, what they advise is that when the patient is intubated, do the nasal packing and then go and scrub in. I'm slightly medializing the middle turbinate. This is a kind of examination under anesthesia. Also, as you can see, I am lateralizing the inferior turbinate. This gives me a wide area for passing two instruments. Can you see immediately the area where we are working has increased just by lateralization. I'm gently putting the ribbon gauze in between the middle turbinate and the lateral wall. This will cause decongestion and also help the middle turbinate to keep it medialized. Again, this will allow us to have a non-traumatic field. We do not want to injure the tissue we don't want to do a surgery on. So gently going step by step, first what I do is I use Tilly's dressing forceps to place the ribbon gauze, and then using Freyer's gently push it in. You can also use neuropatties. If you have long neuropatties, it is actually very good. The neuropatties are made up of cotton and they hold more of adrenaline. You can see the uncinate. Just in 2 minutes, I'll keep on repeating, you can see the amount of decongestion it has caused. It is very essential to have decongestion and a clear field. We don't know what is in the maxillary sinus, so we should be expecting bleeding. This is the uncinate. I'm gently trying to bring it forward so that it will allow me to do uncinectomy. We have got different methods of doing the surgery, retrograde and antrograde. Suit yourself, learn all the different methods, and you can practice or create your own method. There is more than one way to skin a cat. So we are using a backbiter, gently inserting and attaching, getting a hang of uncinate and taking a nice bite. The topical decongestion has already helped. There are different ways of decongesting the sinonasal area, and one of them is using adrenaline. The other way is a head rise to 25 to 30 degrees. It takes the venous blood down. Now we have taken gentle bites of uncinate, and as you can see that the uncinate removal of the lower part has created a nice big area. I will keep on doing it till we have a good field. One more important action of this ribbon gauze which is sitting behind is it will keep on absorbing the blood, and I'm using the suction on the ribbon gauze so that the normal tissue is not injured. Also, one more thing I would like to say is that keep the choana clean, because whenever there is bleeding, it will go and sit in the choana. That will allow us to have more time to operate. Using a curette, I am bringing forwards the superior attachment of uncinate. You have to do gentle maneuvers. All the movement should be meaningful. It's an endoscope. The image is magnified, so any bleeding will be magnified. Some people use debrider at this stage, and also some like to use a 45-degree Blakesley to take the upper part of the uncinate. Here in this case, I am going to use a 45-degree true cut. The true cut is a very good instrument. It has defined control movement. It chops only the areas that we want. I am going to be gentle in this process because, as I said, that the whole idea is to have a biopsy. We are not making a radical surgery because we need to know what is this tissue. If the patient has any malignancy, we may need a further radical surgery. Till now, the whole field is quite clear and there is no bleeding. Always suck the choana first, clean the blood over there, because also it prevents aspiration and it gives us a space where the blood can trickle down. So why do we use this olive tip sucker? The angulation of this instrument is very crucial. It is also atraumatic. Can you see the air bubble which was coming out? That's a good positive sign that we are in the right space. If this was a normal situation, by now we could have seen some area of maxillary sinus. As we are expecting some tissue or something inside, that's why we are not going to have a good look. Now going inside, trying to take a little bit more tissue, but please be careful not to use back. There you see what has happened right now. There is a tissue injury of the inferior turbinate. Now this is something we should be prepared for. Although remember we had lateralized the inferior turbinate, but whenever we are using these instruments, the inferior turbinate can get injured. If there is an injury to the inferior turbinate, it can cause bleeding intraoperatively. Postoperatively, it can cause adhesions if the septal side is also injured. We can use cauterization, and also we can use some ointment to progress healing. Now, while using the backbiter, make sure that you're not using the instrument on the bone. Backbiter is a very delicate instrument. Can you see the pus? That was some pus which was localized. It can be because of blocked ostium. I like to give a lot of washes. In this particular case, we did not use endoscrub. Endoscrub is a sleeve on top of the endoscope which helps to give a wash to the endoscope and keeps the endoscope surface clean. We don't have to keep on using anti-fogging agents. So we could see some pus over there, and now I start using microdebrider. The reason I'm using microdebrider over here is because I know at this moment it's going to be bleeding. We have to make sure that we are working at the same pace as the blood loss. What does this mean? Is that we don't want the blood loss to go ahead of our surgical steps. If there is a lot of blood loss, it will obstruct our field. And the only thing that we'll keep on doing is sucking. We'll suck, we'll give a wash, we'll suck, we'll keep on sucking. And that's quite frustrating. We want to work and keep on working. So this is a very good instrument. The microdebrider, it has a really good suction, and it will keep on sucking the blood, and also it will keep on sucking the tissue which is useful for debriding. There has to be minimal exchange of instruments in endoscopic surgery. So you can see I'm using microdebrider as a suction as well. Keep the microdebrider open. The blade should not be closed, because if the blade is closed, the tissue won't get sucked. How does this act, microdebrider, is that the tissue is sucked in the microdebrider, the blade rotates, there are a couple of movements, oscillating and non-oscillating, and it chops. I'm trying to take out the tissue. I'm focusing only on the back wall of maxillary sinus. Why back wall? Because the medial aspect of the back wall of the maxillary sinus is quite thick. There is very less chance of me penetrating into it. Whenever we want to expose the IMAX or want to go with a pterygopalatine approach, we need to drill that area. The bone is that thick. So that is, I would say, is the safest area. I'm trying to drill. The field gets obscured at times because of the blood. So what do you guys use for defogging agent? You can write down in the comment. I mean, you can use some alcohol or Savlon kind of solution, chlorhexidine solution, or some warm water. These are all things that can help. Also, whenever I'm trying to give a wash, I use warm saline. You can see some more pus coming out. So the wash is also helping me. One more way of giving wash is, what you do is, the olive tip sucker, place that sucker in the maxillary sinus, take the suction out, put a 20cc syringe and give a nice wash. So it's a controlled, directed wash. And can you see the red mark on the endoscope? This is at times when the blood sits on the endoscope and it gets clotted. So we have to keep on cleaning it. You can use multiple washes. There is no harm in giving wash. Just make sure that before surgery you have done a throat packing, because throat pack will prevent from aspiration. How much ever our anesthesia team says that the cuff is inflated, but there can be a small leak. So what are the different ways of controlling bleeding? Firstly, we have to anticipate that every surgery will have bleeding. So number one thing is decongestion is important, but remember the decongestion will act only on the superior surface. As you go deeper inside, the decongestion is not going to act. Low blood pressure, low heart rate is very essential. Head rise to 20 to 25 degrees is very good. Even 30 degrees is good. It helps in decreasing the venous congestion. I like to use a lot of washes. The warm wash can increase the coagulation pathway. It can precipitate the coagulation pathway. So these are a couple of things. Also, there are certain things that are available in the market like Surgiflow, Flow Seal, but obviously we have to make sure that the costing behind it. I'm trying to give a nice suction to make sure that everything is fine. Also, your instruments are your fingers. They give you a tactile feel. And I'm trying to understand that how is the bony anatomy and how far I have to go in. Till now, I have not seen any tissue and I want to take a biopsy. That's the whole goal. Initially, there was no bleeding. Now the bleeding has increased. That was expected, and that's what we are prepared for. Using the debrider, I will try and clear the area more. This is what we are going to expect, and that's why I have put this unedited video. Everyone can sense this. Everyone experiences this. There is no cadaver surgery. So we have to keep on going. We have to make sure that we are not taking too much of time. One advice will be, if there is enormous bleeding and if it's very difficult for you, just pack it and call for help. Because over here, the goal is for the better patient outcome. We are not satisfying anyone's ego over here. It's not a competition. So just pack it and call for help. And if you're alone, then pack it and extubate the patient and do the surgery once more again. Because now there is a thing that we could have thought that would an MRI be essential in such kind of cases? And I would say yes, an MRI would be helpful. But at many times we don't have the time facility to get an MRI done. Now, whenever you're doing this debriding, remember one thing, and this is what I have learned over a period of time, that be careful while you're debriding the inferior aspect of the sinus, also the posterior mucosal aspect. There can be branches of spinopalatal artery and you may debride it, and unnecessarily there will be bleeding, which we have experienced, and if that bleeding happens, you'll have to cauterize. You can use cautery in the nose. There is no harm in using, and in fact, it is very good and suggested that you should use cautery in the nose. You can use bipolar or a suction monopolar as well. Here now I use ribbon gauze, which is soaked in 1 in 10,000, and is the first time I have used since we removed the original pack. And placing the ribbon gauze in. This ribbon gauze which is with adrenaline, will help to decongest the area. All this bleeding is mucosal bleeding, a venous drainage. It can be from the tissue or it can be from the lesion which is sitting inside. So a nice tight pack, wait for 5-10 minutes or a couple of minutes will be helpful. If this was a bilateral surgery, what we would have suggested is that pack on one side, start working on the other side. Okay, go till how much ever time you can, maybe 10 minutes. When that side starts bleeding, pack that side and come back to the original site. By that time, the adrenaline in the original site has acted. So, one more thing that I would like to discuss in such kind of cases is preoperative planning. Number one thing is, if you know that you can do a maxillary sinus antrostomy in 45 minutes or 30 minutes, please request additional 20 minutes in such kind of cases, because we are not sure, and the most important thing is that we do not want to cancel a patient on your list. So take extra time, and hemostasis is very important. So that is one aspect. Second thing is a scan. Make sure the scans are in your brain. Make sure that you're aware about where the anterior thoramoidal artery is. Is it maxillary sinus hypoplasia or not? How high is the maxillary sinus ostium from the floor of the nasal cavity? All these aspects are important. Do we have concha bullosa? Because that is going to cause overcrowding, and that will again increase the operative time. Every case is a different case. Now slowly, after removing the ribbon gauze, you can see there is a slight improvement in the whole ostium. There is something in the maxillary sinus I was feeling which was not right. It was quite hard. I looked at the scans again and I could not see anything that kind of structure. So is it a calcification, or we don't know, or the tissue has become just hard over a period of time? And this can be the most frustrating time of the surgery. That is, it is bleeding, we can't see anything, and there is something hard over there. And this is the moment when we decide what to do next. We can stop and call the patient again, or just pack, get a good hemostasis, have a relook at the scans, replan. It's a continuous process. Surgery has to be a dynamic process. We have to have multiple options and backup plans what to do. I like to give washes. By now you would have understood, and there is no harm in giving washes. It helps a lot. I could feel that there was a bony calcification in the posterior wall. This bit of tissue was obstructing the view, so using a 45-degree Blakesley, I removed the tissue. You know, in textbooks and in literature, we have been given a guidelines or a standard of procedure, but we should be able to adopt some variations to that. Surgery is an ongoing thinking process. It has to be dynamic. At times we have to twist and turn the instrument to get an access. Everyone's anatomy is different, and every case is a special and different case. We have to be prepared for that. Till now, I'm very happy with the decongestion. The bleeding is just restricted to the maxillary sinus. It can be because of inflammation or the tissue which is sitting over there. This is the first chunk of tissue which I get, and it is different from the mucosal lining. It was quite friable, so this gives me a confidence, and I decide to go further. And you can see now the maxillary sinus is open more. The back wall is seen nicely. At this point, we can think, shall we use a 30-degree scope because we are struggling, or shall I just continue with 0-degree scope? We know that 0-degree scope, many people use to do lot of surgeries. People do draft or any other cavernous sinus surgeries even with 0-degree scope. Make yourself comfortable. Just because your loved surgeon does the procedure that way, you don't have to stick to it. You see, there are different ways of holding a knife while chopping a carrot, and people have their own methods of cooking. So using this olive tip sucker, and this olive tip sucker, as you can see, is quite smooth, so whenever it touches the other tissue it doesn't cause any trauma. And trying to get inside the maxillary sinus slowly I'm gaining confidence that we are approaching to the area where we want biopsies. Going with again 45-degree instrument, going inside, I can turn around and go all the way to the floor. I take couple of tissues. The area that I'm dipping in is anti-fog solution. So suction, biopsy, suction, biopsy. We have to be patient. Do the same thing again and again. The whole time the camera or the endoscope has been oriented well. The image is in the center. Remember that while we are operating, we should not go far away from the floor of the nasal cavity. Because if we lose the sight of the floor of nasal cavity, we tend to go higher and higher. And there's a chance of injuring the lamina or skull base. This is quite repetition, but what I'm trying to do is suck the choana first. Why? Because if there is any bleeding, if any vessel is exposed, the first thing will be blood will go into the choana. It will fill the choana. It will allow me to get a couple of extra minutes to control bleeding. That's why. Now I'm trying to give wash the same way, putting the olive tip sucker in the maxillary sinus, giving a wash. It will help to take away all the debris, the clot, and give me a better view. Let's see what we can see over here. At this moment, I actually thought that time, shall I use a curved blade? You know, on our debrider, we get a curved blade as well, which are really good to debride the maxillary sinus and the frontal tissue. So I was actually thinking, but I was getting a good view of the posterior wall, and all I wanted was that little bit of more tissue and then come out. So what I decided was, okay, fine, I'll just go with a micro debrider, the straight one, not a curved one. So it's been 15 minutes since we have opened the ostium and we are not progressing. I give wash, hemostasis, okay, good. I can see the back wall of maxillary sinus, but I cannot get a good view of the tissue that I want to take out. And I know that there is some tissue inside because I got a couple of biopsies before. So usually I use only 0-degree endoscope, but now I decide, okay, enough is enough. Let me switch to 30-degree endoscope. We take the 0-degree endoscope out and put a 30-degree endoscope. Whenever we change the endoscope, make sure we are redoing the white balance, and focusing is also very important. So white balance, many times we have the button on the camera head itself. So we do the white balance and making sure it's all well focused, as you can see. And once the white balance is okay, the image is centered, we start again. There are a couple of ways of using 0-degree endoscope. Firstly, people say that either you go facing downwards or facing upwards. I like to go facing downwards because for me, the floor of the nasal cavity is the safest area. I don't get lost in the orientation. After using the scope, I try to turn around and see where I am. At this moment, I get a feel that, okay, there is hardly any change in using 0-degree and 30-degree, but why not? Let's proceed. We have taken a couple of biopsy tissues already, just making sure that we are not seeing anything obvious and missing out. I can see the back wall of the maxillary sinus. So the whole purpose of this surgery was examination under anesthesia, get a couple of biopsies, and wait for the tissue diagnosis. So we have done our examination under anesthesia. We have taken the biopsies. Okay, now hemostasis wise, I'm fine with that. What we'll use is, we'll use some hemostatic sponges which are available in the market. These surgeries are day case surgeries that the patient has 3 to 4 hours of recovery. Once the patient is eating, drinking well, the patient goes back. This is the hemostatic sponge. it gets dissolved on its own. There are certain other foam and gel based, but in this case I want a pressure tamponade as well. So that's why using this sponge. It takes around a week to get dissolved, and we advise the patient to do nose rinsing, nose washing after 2 to 3 days. Don't forget to remove the throat pack. Thank you for listening. If you have any comments and questions, please write down in the section below. Please do not forget to subscribe, like, and share. And also, you can have bleeding when not expected, and be prepared for it. Thank you.